Hello, I'm Roger Watson and I'm the Professor of Nursing at the University of Hull. I am also the Editor-in-Chief of the Journal of Advanced Nursing. What I want to do today in this very short presentation is to talk to you about nurse-led care and extended nursing roles, and within that I will be looking at some of the evidence and also talking about nurse prescribing. Thank you very much for the opportunity to come and speak to you. First of all, why do we need nurse-led care and extended nursing roles? And this is not just from a UK perspective, this is from an international perspective. Worldwide, we have an ageing population, and this requires more healthcare and therefore more nursing care and a different kind of nursing care. The prevalence of non-communicable diseases is increasing. Communicable diseases are still prevalent in developing countries, but in the developed countries, non-communicable diseases are increasing, and these are often highly suitable for care that is led by nurses. There's a global shortage of doctors. I don't think that's a particular problem here in China, but in most countries it is the case that we have a global shortage of doctors. Very acute in developing countries and in several developed countries. And nurses, particularly nurses with extended roles and a higher level of skill, can to some extent compensate. Also, care is moving from the acute to the community sector. And again, nurses are ideally placed to lead and to provide care in the community sector. And we haven't got to forget the rising costs of healthcare. And while as a nurse I don't like to say this, nurses are cheaper to train and cheaper to employ. So there is some cost benefit in using nursing care as opposed to expanding medical care. What are the hallmarks of extended practice? Now, I'm using the expression extended practice here as a generic term to cover a wide variety of different kinds of extended practice by nurses. I'm not referring to any specific role, as you will see. But the hallmarks of extended practice are advanced education. Nurses who have extended roles need to be educated, and this is normally at least to the level of master's education. They need to have their own caseload responsibility. They can't be utterly dependent on doctors or on the medical profession for their caseload. There must be some ability to carry and be responsible for their own caseload of patients. They must have skills in diagnosis. They must be able to discharge patients, not necessarily from the hospital, but perhaps from the hospital into the community or to other areas of care. And I think one of the most essential hallmarks of extended practice is that they must be able to prescribe their own medications, if not the complete pharmacopoeia, at least a section of that that is relevant to their practice. So what is the situation in the UK regarding advanced roles and extended practice? Now, I am not holding up the UK as a paradigm of virtue here. We've made some mistakes along the way, I think, and I think seriously that China can learn from these mistakes. I know the Chinese education system very well. I know that you have clear educational goals that nurses need to achieve, for example, for promotion. And in the United States, for example, there are clear educational goals to be achieved for extended roles. Unfortunately in the UK, we've allowed the situation to get a little bit out of hand, as you will see. So our problems in the UK are that we have too many titles. There has to be some rationalization of these titles. It's actually very difficult in the UK sometimes to understand from the title of a nurse what it is that they do. It's also very difficult to understand exactly how they're regulated, and some of these roles, as you will see, are not regulated. And one glaring problem in the UK, which I'm sure you will not fall into in China, is that there are no agreed educational standards. For example, the standard of education required of an advanced practice nurse in the UK is master's level education, but it doesn't mean to say that they have to graduate with that master's. They simply have to undertake it. They don't have to necessarily collect it together as an MSc degree. And I think that's wrong. I think it's wrong because it's hard to identify how well educated that nurse is. The nurse is also not being given credit for the educational programs that they've undertaken. So the range of titles in the UK is very confusing. We have clinical nurse specialists, nurse practitioners, advanced nurse practitioners, nurse consultants, and many other titles. And while some people try to define these and claim that they are different, actually they're either not very different or they're so difficult to describe that it's very difficult to know exactly what they do and where they work. One of the issues in the UK is that most of these positions have grown up in local hospitals and local health areas, and there hasn't been a national strategy for them. And our nursing regulatory body, the Nursing and Midwifery Council, has taken very little interest in this. So, as outlined in yellow there, it says, at present in the UK there's no central regulation, no defining qualification or training, and I've added there for advanced and specialist nursing roles. This work comes from a study carried out at King's College in London and funded by the Burdett Trust for Nursing. On the other hand, a range of qualifications are deemed to be recordable. This means that when you are registered, you can also record these. But being recordable does not mean that the regulatory body takes any responsibility for the level of education or for the level of, for example, discipline or regulation if something goes wrong in these roles. I'm not going to read all of these roles out, but there are various roles that are currently recordable. Some of these are prescribing roles like community practitioner, nurse prescriber, and independent nurse prescribers, for example. And there are a range of specialist practitioners in mental health, children's nursing, and so forth that are recordable. None of these say advanced nursing practice, and yet the role of the advanced nursing practitioner is growing steadily in the UK, and also, for example, very specialist roles like advanced critical care practitioners. But these don't appear anywhere on the register, and they are not recordable. It's also worth noting that there are a great many other specialist practitioners. As I said at the beginning, specialist and advanced and extended roles are very suitable for some of the non-communicable diseases, and we get clinical nurse specialists working in diabetes and rheumatoid arthritis, for example. So from this article by Coombs in the BMJ in 2008, which is sarcastically titled "Doctor, Nurse Will See You Now," it was about the growth of extended roles in nursing, and it wasn't against having these roles, but it was pointing out how difficult it was to know what advanced nurses did in the UK. And it says this here also, which is strange because the lack of registration and recording, it's impossible to know quite how many nurses are working in advanced roles in the United Kingdom. So that's one question that I can't answer for you, but in most countries, if you ask how many advanced and specialist roles are, they will know exactly, because these will be recorded somewhere and registered somewhere, and they will have to be registered somewhere. So I just want to point out that I think this is something that if you're developing these roles in China, that you need to work very hard to make sure that they develop properly and that they are regulated properly, but I have every confidence that you will do that. However, given that we have these advanced roles across the world, is there any evidence that these roles are effective? I get a great many articles into my journal, the Journal of Advanced Nursing, and I've done some work and reading up on this, and there is evidence that these roles are effective. I'm going to look at 2 reviews in this area. I'll be looking at some more evidence later related to nurse prescribing, and this review of nurse practitioners in aging care from the Netherlands came to the conclusion that physician substitution in healthcare for the aging population may achieve at least as good patient outcomes and process of care outcomes compared with care provided by physicians. We still need to gather more evidence about cost and the economic benefits of this care. But the basic message is that using nurses to provide care that would normally be provided by doctors is, on the whole, just as good. And there's also this study in the International Journal of Nursing Studies from Switzerland, looking at the care of older people by nurse practitioners, and it's a scoping review. This review came to the conclusion that it demonstrated improved or non-inferiority results of nurse practitioner care in older people across settings, and this was compared with physician care. Now, non-inferiority studies are somewhat controversial as the level of inferiority is set by the investigator, and I didn't see the protocol for the study. It should be set before the study is carried out. However, they're becoming increasingly popular, and the message is that the care provided by nurse practitioners is as good as the care provided by doctors. Now, I want to point now, having pointed out some of the problems in the UK, I want to point to a success story in the UK, and that's the case of nurse and non-medical prescribing. Now, just to say that nurse prescribing has been with us for probably about 20 to 25 years. It's quite hard to pinpoint exactly when nurse prescribing was brought in. It's now usually referred to under the umbrella term of non-medical prescribing because there are a great many other practitioners who can also prescribe, but nurses are by far in the majority. It's become so clearly an effective part of practice and a seemingly cost-effective part of practice that there have been some considerations at government level in the UK in making nurse prescribing part of the undergraduate curriculum. This hasn't happened yet, and I have to say it would be quite difficult to see how we could do that within a 3-year programme, also given the level of biological and physiological knowledge and indeed pharmacological knowledge that these nurses need, which isn't usually provided in an undergraduate degree. But there are moves afoot to make all newly graduated nurses non-medical prescribers. However, that hasn't taken place yet. But it is one of our success stories. And as I say, the UK government's considering implementing this into the undergraduate curriculum. The most recent data that I can find is from this RCN, that's the Royal College of Nursing, one of our professional bodies' fact sheet about nurse prescribing in the UK. And as I say, the most recent data that I can find is from 2014. And at that time, and the facts and figures are from 2014, there were over 54,000 nurse and midwife prescribers across the UK and over 19,000 nurse independent and supplementary prescribers. These are slightly different, as you will see, and there is evidence of improvements in access to medications, patient safety and patient care. So the picture is very positive. Having said that, there are something like 300,000 nurses working in the National Health Service alone in the UK, and a great many more on the nursing register. So the numbers are still relatively small, but they're getting bigger, and there are plans to make them even bigger and more widespread in the future. This article from 2016 on the expanding role of nurse prescribers, which is in a journal called the Prescriber. And here you see the different kinds of nurse prescriber. There's the independent nurse prescriber at the top. At the bottom there are supplementary prescribers, and in between there are community practitioner nurse prescribers. These different levels are representing different levels of an ability to prescribe. Nurse independent prescribers, for example, many advanced nurse practitioners and critical care practitioners are nurse independent prescribers, and they can prescribe any drug within their area of competence. They can prescribe antibiotics, analgesics, including controlled drugs, and antiarrhythmics if they're critical care practitioners, for example. So they really prescribe everything that their equivalent medical practitioner would prescribe. The other levels of practice have more, of prescribing, have more specific and focused levels of prescribing, which are much more related to their roles, but they don't have the freedom to prescribe that nurse independent prescribers have. And just as a matter of interest from the same article, what are the drugs that different prescribers prescribe? You can see here that there are different kinds of prescribers: community prescribers, pharmacists, and other allied health professionals, for example, physiotherapists. But nurse independent prescribers are the most common type in red, and the kind of things that they prescribe for on the whole are minor ailments, pain, wound care, skin care, that kind of thing. And down at the bottom, more less commonly prescribing in oncology, rheumatology, and neurology. So there's a range of different drugs that are prescribed most commonly by nurse independent prescribers, and that makes perfect sense because it's related to the kinds of roles of these nurses. But what's the evidence for the effectiveness of non-medical nurse prescribers? Well, this article is about non-medical prescribing versus medical prescribing for acute and chronic disease management in primary and secondary care. It's a review from the Cochrane Library, and the Cochrane Library is considered to be the gold standard for systematic reviews and evidence. And here the findings suggest that non-medical prescribers practicing with varying but high levels of prescribing autonomy in a range of settings were as effective as usual care medical prescribers. And there's other information there about the kind of drugs that they were prescribing. But the important message is that non-medical prescribers in a range of settings are just as good as medical prescribers. This next piece of evidence, again from the Cochrane Library, is more focused on a particular kind of prescribing. This is about nurse-led titration of angiotensin converting enzyme inhibitors and other drugs for heart failure with a reduced ejection fraction. It's very specific and very focused, as you can see, but participants in the nurse-led titration group for all these drugs experienced fewer hospital admissions for any cause and an increase in survival and in the number of participants reaching target dose within a short period of time. So nurse-led titration is one strategy that facilitates the implementation of this evidence into practice. In other words, nurse-led titration compared with medical doctors doing the same thing is very good and has very positive outcomes. So I would thoroughly recommend the development of nurse prescribing in China, and I know that there are different areas in China where I've visited and consulted and been asked about this, where nurse prescribing is being seriously considered and may indeed already be under development. And finally, I want to advertise my own University of Hull. The University of Hull was probably the first university in the UK to introduce a program on nurse prescribing, now called non-medical prescribing. I don't know the exact date. We claim to be the first, but I don't have the hard evidence for that, but we've certainly been doing it for more than 20 years. These courses, however, are now very, very common in the UK, but at the University of Hull we've got a very long history, and possibly the longest history, of providing these programs. If you want to know any more about that, the web address is there. You may have these slides, or indeed, if you don't have these slides or don't have time to copy down the URL, don't hesitate to contact me. This is my email, r.watson@hull.ac.uk. You can check me on ORCID and find out about my publications and research experience. You can't follow me on Twitter, I'm afraid, because you're in mainland China. However, you can scan my WeChat QR code, and you're welcome to follow me and to keep in contact with me by WeChat. Thank you very much for the opportunity to speak to you today. I hope that was useful. If I can take any questions, I'll be very glad to do so, either now or in future by email. Once again, thank you very much and goodbye.